Hi, everyone. Welcome. I'm Rachel Goldberg. I'm a licensed therapist. Today, I'm thrilled to welcome Dr. Susanna Park. She's a fertility specialist at San Diego Fertility Center with over 20 years of experience, including a decade at Columbia University. She's been named top doctor 5 times and is known not just for her clinical expertise in IVF, egg freezing, and third-party reproduction, but also for how deeply she cares about individualizing care. And I can attest to that. She's a very lovely person, and many people rave about her that go to see her. Dr. Park, thank you so much for being here. I want you to take it from here and just tell us a little bit about yourself, and then we will get started with the questions.
Oh, gosh. Okay. I've been a fertility doctor now for about 21 years. I was born in Korea, raised in Argentina till I was 6 years old. So I speak Spanish and then moved to New York. I've been a New Yorker for almost 40 years. And then I moved out to California about 12 years ago.
All right, so here we go. What are some possible reasons for embryo arrest in the morula stage?
Just so everybody knows what the stages are, right? When an egg and a sperm come together, that's what you call an embryo. And then the embryo, the self-compact, usually around day 4. And then it should open up to become a blastocyst. So I think what the question is asking is, hey, after you have day 3 embryos, why do they, when they compact, they don't expand to become a blastocyst? So it's either sperm or egg. In many cases, if you're doing an egg donor, it's probably sperm. But if it's a woman using her own eggs, especially if she's older, it's most likely egg. And sometimes, honestly, like we've had embryos that are from egg donor and a sperm donor, and it doesn't survive. So then, of course, we always think, oh my gosh, is it the lab? So what we do is, so like when I do my IVF, I batches. So I have a bunch of cycles going at the same time. So we look to see how the other cycles in the lab are doing. And if the other cycles are fine, especially if the other egg donor cycles are fine, then I don't think it's a lab issue. I think, okay, there's something going on with either the egg or the sperm, but that's usually what it is.
Can you talk about subchorionic hematomas? Can they be diagnosed before 6-week ultrasounds? And then is there a way to prevent or treat them?
Hematoma, the acronym we use is SCH. So that is where your cervix pregnant, and then you have that pregnancy sac called the gestation sac. And then right next to it, you see this gray colored fluid. It's like a cavity, and there's fluid inside, and that fluid is actually blood. And we actually don't know why it occurs. It's actually quite common with IVF pregnancies. But the problem is, especially that subchorionic hematoma, is if the pregnancy is up here and then here's the hematoma and here's the cervix, many times the pregnant woman will just start to bleed, like hemorrhage bleed. And it's really not the pregnancy bleeding, it's the hematoma evacuating the blood. So yes, you can see it before 6 weeks because usually the first ultrasound is done at 6 weeks. So that first ultrasound, you can usually see it. Yeah. And how do you prevent it? You can't. It just happens and it resolves on its own. So we tell women to get off their low-dose aspirin because aspirin makes the blood thinner, so it makes them bleed more. And then pelvic rest, so no sex, right? Just limit your activity because you don't want this thing being moved, jostled too much because then they'll bleed more and the body will just slowly just resorb it.
How often have you had success with 44-year-olds conceiving and having healthy babies?
Oh, great question. Not very. So the oldest documented IVF patient in the world was 46. My personal oldest was 44. She did 9 IVF cycles. She turned 45 during her IVF cycle. And she did have a daughter. But the daughter came from her 44-year-old cycle, not from her 45-year-old cycle. And in my 21 years, my one patient. Yeah.
Would you recommend requesting Mosaicism status on embryos if the lab, it's Juno Genetics, doesn't routinely report it? And if a lab only labels embryos as Mosaic without clarifying low versus high level, is it still useful to have that information?
That's a good question. And the first question was, hey, this lab just says normal or not normal. I think it is helpful to know if something is mosaic or not. And then it does get further subdivided into low mosaic or high mosaic. And it is believed that high mosaic is probably abnormal and low mosaic is probably normal. But even because our lab does differentiate that. But even so, we still put those embryos in the very bottom of our list, right? So we still go through the normals first. I have personally transferred a number of low mosaics that have turned out to be healthy babies. So I am a big fan of transfer of mosaics. I even transfer abnormals, but especially low mosaics. I haven't had the same luck with high mosaics or abnormals. So to that end, I do think it's worth knowing that information. But at the end of the day, if you have a physician who's willing to transfer these abnormals, it really comes down on the stance of the intended parent and their stance on abortion, right? Because if they're saying to you, look, I'm very pro-choice, so then my thinking would be, then why don't you just put these embryos in and see what happens? Do you really have to know if it's mosaic or not? But if somebody says to me, I don't feel comfortable with termination, I really just want to know this because I don't want to put it in if it's not normal because I don't believe in termination, then I think for that patient, it is important to know if they're mosaic or not because maybe it's not worth taking the risk.
Okay, thank you. Why might an REI suggest a male test to measure sperm DNA fragmentation after a round of IVF that resulted in 14 retrieved, 12 fertilized, and 3 embryos?
Okay. Were these eggs egg donor eggs by any chance?
Yeah, that I don't
No.
know.
Okay, that's okay. 14 eggs retrieved, 12 mature. So I don't know what the fertilization rate was, but generally it's about 60 to 80%. So the 12 mature, let's say 9 fertilized. And then of the 9, generally about half will make it if these are egg donors. So let's say half made it and then PGT were tested and 3 normal. That seems like a pretty average cycle. But I do DNA fragmentation, especially when the guys are older, like usually mid-40s or older. I'll just get it proactively because I just want to brace them for, oh, hey, your sperm DNA fragmentation's elevated. Even though I know we don't know how to really fix it, just heads up that your IVF cycle may result with poor blastocyst development. Or I do it when I have an IVF cycle, and even in a young guy where I'm like, oh my gosh, what happened? Why is it so bad? So for this particular cycle, it's an average cycle, but maybe the REI felt, oh, could have been better. Maybe that's why.
To piggyback on that, someone else asked, when sperm DNA fragmentation is high, do you approach ICSI any differently?
No. So there are a couple things that people suggest. One is that if you ejaculate daily for a few days, so the belief is that the fragmentation happens because so even though guys make sperm all the time, the sperm is actually stored in what's called the epididymis. And the belief is that if the sperm is stored there for a long time, it tends to be more fragmented. So one of the tactics, which none of this is proven to be definitively effective, but you have the guy ejaculate daily for 5 days. So that by the time it's their 5th day of ejaculation, that sperm is like has been there as short of a time as possible. But what we do is we have this machine called a sperm separator, which allegedly separates out sperm based on DNA fragmentation. So when I know a guy, and you have to have enough sperm to put in the machine. So you can't have a guy with oligospermia with like low sperm count that cannot go through the machine. But when I have a guy that I know has high fragmented DNA, I tell the lab, please, please, please try to put the sperm through the machine in hopes that what the machine kicks out will be sperm allegedly that's less fragmented DNA.
Is the machine you were talking about for the sperm fragmentation, is the machine the same as the Zygmot? Is that how you say it?
The Zymot, yeah.
Okay.
Yeah, but they're different. Zymot is a brand. They're different, similar machine. Correct.
If someone had 4 late miscarriages, 2 with own eggs and 2 with donor eggs, did all the checkups and was diagnosed unexplained, do you suggest any other options?
Yeah, so when the person says late miscarriage, I'm going to assume that means not first trimester. Okay. So yeah, if somebody has had 4 miscarriages, of course, first trimester miscarriages, number one reason, incorrect number of chromosomes. Okay. But if you're having second or third trimester miscarriages, that is not incorrect number of chromosomes. That is, there's something wrong. And so, yes, at that point, I would consider surrogacy. Yeah.
Thank you. So next question is, after multiple failed euploid transfers, how do you know when it's time to consider donor eggs or a gestational carrier?
Oh, I know. That's a hard one. So in women in their 40s, even though I know that PGT is euploid, when you do PGT, you're only looking at nuclear DNA, right? Like there's still DNA in the mitochondria. That's not included. And remember that when a woman is using her own eggs and you're putting sperm into it, the organelles of her eggs, the mitochondria, the ribosomes, all of that is the powerhouse for this embryo. So if her mitochondria is not strong, that embryo is not going to be strong. And that's why even though you transfer PGT normal embryos in women in their 40s, their implantation rates are actually lower than if you have a 30-year-old with a PGT normal embryo. So if I had a woman who was especially older and we're still transferring these euploid embryos and she's not getting pregnant, I'm not thinking surrogate, actually. I'm still thinking eggs. If I have a 30-something-year-old and she's got these beautiful euploid embryos and they're not sticking, then I'm thinking, wait a minute, I don't think it's eggs here. I think there's something about her body that's just not sitting well with these embryos.
Next question is, I'm starting my cycle tonight and will be fasting on Sunday. Could this affect my cycle or medications?
You're starting your IVF cycle tonight. So when you fast, I assume you fast, is it from,
Probably sundown to sundown. It's a holiday.
right? One day of not consuming calories should be fine.
Okay. Would you recommend doing endometriosis surgery before a second egg retrieval? I'm 34 and had one normal PGTA tested day 7 embryo. My ultrasound showed signs of endometriosis.
Okay. So just to be clear, if your ultrasound showed signs of endometriosis, the only sign would be a cyst on your ovary called the endometrioma, because you cannot see endometriosis on an ultrasound. Okay. So endometriosis is when cells inside the uterus develop outside the uterus. And that's normal, by the way, but you should have cells in your body that just gobble them up, so they should be non-existent. But in endometriosis, those cells that fall into the pelvis outside the uterus don't get gobbled up, so they implant and then they wreak havoc. So we know when women have endometriosis, unless you have a cyst on your ovary, that is the characteristic endometriosis cyst, the only way to definitely diagnose it is by laparoscopy, okay? The camera on the belly button, because you have to look for these lesions. When women have endometriosis, it is associated with decreased egg quality. It's also associated with decreased implantation, and we don't fully understand why. So, of course, that leads to infertility. The thing about the IVF, though, is I would get your IVF stimulation cycles out of the way before you do endometriosis surgery, because when you're taking these IVF drugs, your estrogen levels rise, and then that can make your endometriosis worse. So one of the things you may want to do, in addition to your IVF drugs, be put on letrozole, because that keeps your estrogen levels low, but you're still making the eggs. So your sequence of events should be get all your stimulation out of the way. And then before you're about to do your transfer, if you want to get your endometriosis surgery done, go get your laparoscopy done, clean out your pelvis, because you're most fertile right after you've had your endometriosis surgery, then do your transfer. Now, if the question though is, oh wait, no, I've got this big endometriosis cyst on my ovary. And if you do, and that's not letting that ovary make eggs, then the question is, do you get that cyst removed before the IVF? But the problem is it's a double-edged sword, because if you have endometriosis surgery done and you're scooping out the cyst from your ovary, when you take out any cyst from the ovary, you are taking out future eggs. So you're shooting yourself in the foot, because while you're clearing out the cyst, you're also taking out future eggs. So what I do is I really, really try not to do cyst removal before retrieval. And I just try to work around the cyst, because I don't want to remove her future eggs.
Wow, that sounds complicated and unfortunate for that. Something like that. Okay. What supplements actually make a difference in making health optimal for egg retrievals and first embryo transfers?
Oh, yeah. Such a good question. And the honest answer is there's nothing scientifically proven. Okay. But I'm sure many of you have heard about that book, It Starts with the Egg. I just tell people to read the book only because And I'm sure there are so many other supplements out there, but at least somebody put it together in one book. So I tell people if they don't have an acupuncturist to read that book, take it with a grain of salt, right? Because it's a lot of supplements and people may say, oh my gosh, I don't want to take all these supplements, but it's a guide. When I have patients who work with acupuncturists, many of the acupuncturists, especially here in San Diego, also do supplements. So I tell them, hey, just listen to the advice of your acupuncturist and they will guide you with regard to what supplements you should be taking. My philosophy on this is there's so much you cannot control, but you can at least control your lifestyle, how you live, what you eat, what you expose yourself to. So my philosophy is why not? Take the supplements. What do you have to lose? Yes, I know money because these supplements are expensive, but at least you feel that you've given it your best shot. So I'm a very pro supplement person, yes.
Is there a favorite you have?
No.
Okay. Okay. What's your take on duo-stim for low responders in their 40s? Is it worth it or just more physically taxing?
Okay. So just so everybody knows, for the dual stim means that somebody just did their retrieval, but the trigger you use is Lupron because what Lupron does is it makes the eggs ovulate, but there's very little support for the follicles where the egg came out from are called corpus luteum, and they make progesterone, and that's what will sustain you and prepare you for pregnancy. But when you give somebody Lupron, that corpus luteum just dies so fast. So that's good because it preps you to be able to go straight into another IVF cycle, right? So that interval of 5 days, it's very short. I've done dual-stim a few times, and I've had success with some of them, and I've had some dual-stims where it's been like, wah, wah, right cycle, my goodness. I think it's worth trying. When you have patients who really are diminished ovarian reserve, I think it's worth trying as many different protocols as you can until you reach a point where yourself as a physician, but especially the patient feels that, yeah, we gave it our best and we tried many different options and it didn't work. So I'm ready to close this chapter. So it's not a magic formula. There is no magic formula. I tell people with diminished ovarian reserve, did you know that when women are super young, are egg donors, like most of the world uses the same protocol because it works so well. And did you know when women have low egg reserve, there are like 50 different protocols because none of them work well consistently, right? So I tell people, let's try different protocols, but eventually the patients get to a point where they feel that, yeah, you know what? I've tried and I'm ready to just call it quits now. So yeah, I think it's worth trying if the patient hasn't tried it, if the patient's interested, sure.
When do you recommend ERA, Receptiva, or similar tests, and when are they not helpful?
Yep. So this is very clinic to clinic. So there are some clinics that mandate ERA. That's the endometrial receptivity assay, where you put somebody through a cycle. The day you would do a transfer, instead you would do a biopsy. That tissue gets sent to the company. They look at the protein expression and tell you, oh, you should be transferring after X number of hours after progesterone exposure. Okay. So there's some clinics that mandate that on everyone. We are not one of those clinics. I personally don't believe in it. I have had patients who come to me with ERA from another clinic because there's a clinic here in San Diego that does it in all their patients. And then the patient says to me, hey, can I just repeat it again? Because it's been a while. I said, sure, if you want. And wouldn't you know it, one ERA would say day 6, and then of course the repeat says day 5. So then I say to her, now what do we do? I don't know, right? So I just cut the difference. So no, I don't recommend the ERA routinely. The only time I will recommend it is if I have a patient and we've transferred the first transfer and either it doesn't work or biochemical, but something is off. Same thing, second transfer. At that point, I will say to her, okay, now we've had 2 transfers and it hasn't worked. Now it's time for me to pull out the kitchen sink. So now we're going to go over all the stuff, hocus pocus, but let's go over it. And one of them actually is ERA. So I will recommend it after I've been struggling, but I don't recommend it after.
What's your take on using growth hormone during stims?
I'm a big growth hormone person. Like I have pulled off some miracles with that growth hormone. But I've also used it and it's been no difference. But I would say most of my cycle, I have seen an improvement with growth hormone. So I am a very big growth hormone person, but like I don't do it on egg donors. I'll do it if I have a 34-year-old with great egg numbers, I don't do it. I generally do it on women where their egg numbers are so too bad. I'll just do it out the gate first cycle. Let's say they're 37 and their egg numbers are pretty good. I won't do it, but if that cycle is not great, then I will suggest it for the next cycle. Yep. I actually just had a donor. I know this sounds crazy, but her numbers, she had a terrible cycle, but her numbers didn't look so bad. And they insisted on using her again. And it was such a bad cycle. And I put her on growth hormone and we just got the results and it was night and day outcome.
That's amazing.
Yeah.
That's a great thing for people to know, I think. If someone has a higher BMI, would you suggest GLPs before an egg retrieval?
Good question. I think it depends on how high the BMI is. Our center will not do a retrieval if your BMI is over 40 because we're an outpatient facility. We are not connected to a hospital. So God forbid there's because the problem with a high BMI is the airway, right? When you have so much mass, it's really hard to intubate somebody as an emergency basis. There's just too much tissue to go through. So when somebody is obese, we actually will intubate you. But if your BMI is over 40, we tell you, listen, please, we need you to lose weight. And I think GLP is a great way to go to lose your weight quickly. But then once your BMI is under 40, we will do your IVF, but we will intubate you still.
Would you transfer an abnormal embryo?
Not all doctors will. I do, but there are a few stipulations. Number one, you have to speak with a genetic counselor to understand what is this abnormality? Like, what does that mean if it's real? What are the clinical implications of that? Right? The option of, are you going to terminate? That needs to be discussed. And I would say my abnormals have resulted in either no implantation or miscarriages. I have yet to have a live birth from an abnormal PGT, but granted, these are from women who are older where the PGT probably is real. But I have had live birth from low mosaics.
In what situations would you consider transferring more than one embryo?
So I'm one of those few docs that will transfer two, even with egg donor embryos. So I'm probably not the best person to ask that. But the truth is that the safest truly is one embryo. It is the truth, right? Because when you have more than one, there's high risk of diabetes and high blood pressure. But the scariest, of course, is premature delivery, right? And when babies deliver prematurely, nothing is ready. The heart, brain, lung, intestines, nothing is ready. Nothing's mature. So that sets them up for increased medical complications. Of course, they have to be in the neonatal intensive care unit, the NICU. So that comes not only with its medical risks, but also financial, right? You have to pay your co-insurance, right? So it is true. Transfer one really is the safest and the healthiest. I still will transfer two, but again, stipulations. Number one, you have to speak with a high-risk obstetrician to fully understand what does it mean to be pregnant with multiples, especially for my intended parents who don't live in the United States, right? People who live in the United States, if you have American health insurance, it will cover the hospitalization of your baby. You still have to pay whatever your copay and co-insurance is, but at least it covers part of the hospitalization. For my intended parents who don't live in the United States and they don't have private insurance that will cover their baby in the United States, because some people do, I tell them, hey, did you know that insurance for twins is like really expensive in the United States? And when they hear that, they're like, oh, wow, we had no idea. I said, yes. And then if some people choose to gamble and not get insurance, and I tell them, do you understand that the NICU stay in one day is X amount of money in the United States? And so for people who don't live in the United States, I strongly discourage it, just really for, in addition to the medical reasons, but financial reasons. But I have people who ask me, even in the United States, especially if it's going to a surrogate, they say to me, we don't have the money to do surrogacy twice. It's usually two guys, right? And they say, we just don't. So this is a one-shot deal. We just want the opportunity to both have a baby. And if it doesn't happen, it doesn't happen. But we just at least want the opportunity to put two embryos in, and then it is what it is. So that's usually the circumstances where I'll do it. Like I have a patient now who's 40, she was 42, 43, 44 when she froze her eggs. And she has embryos. They're not tested. And she wants to transfer 3. To me, makes sense. Right? They're not PGT tested. She's not going to get triplets. Right? So cases like that, absolutely, I will put in 3. Sure. Because she's not going to get pregnant with triplets.
Dr. Park, hearing that, you might start getting some phone calls because people are
Oh,
like, oh,
God.
I know now there's a doctor that'll do it. Okay. What would you suggest to someone who starts out with a double-digit number of follicles but can't seem to get more than 3 eggs each cycle despite numbers being okay? So far, no explanation from her doctor.
That's a tough one because that means your attrition rate must be significant, right? You're losing a lot of embryos during the IVF process. That's tough. So I don't know how many types of different protocols you've tried, but I would definitely just try, like we mentioned the growth hormone earlier. Like this may be a great case where you say, hey, let me try that growth hormone. The other thing you may want to do is change your trigger. I know when women have a lot of eggs, understandably, the doctors get scared, right? Because the more eggs you have, the more HCG you put in your trigger, the greater your risk for ovarian hyperstimulation syndrome. Absolutely true. So then you tend to use a weaker trigger, but weaker trigger has higher risk of less mature eggs. So one of the things you can do to try to use a stronger trigger is use letrozole during your IVF cycle, right? With your start of your IVF drugs to the end of your IVF drugs, that will keep your estrogen levels low, which then will let you use a stronger trigger, which will hopefully improve the number of eggs, right? Because the trigger is what pulls the eggs out of the follicle. So number of eggs and 2, the maturity of the eggs. I would try that, try the growth hormone, try to change your protocol.
Okay. It's interesting that you said the oldest in the world is 46. So does that mean everyone we hear of doing IVF after that is using an egg donor, or is it happening naturally?
Sometimes it does happen naturally. There are one of the docs here in San Diego. He's a high-risk obstetrician. His wife got pregnant at the age of 50. They did not think they were going to get, they weren't trying to have a baby. They were just having
Wow.
sex. Yeah.
Wow.
Yeah, just like that. No, yes, it can happen naturally, but documented is 46. And I've had 48-year-olds trying to do IVF. Yeah, I've tried, and like, they just don't respond to the drugs. But again, I think a lot of it is you don't want to look back on your life with regret, right? So even if you're 48 and you feel as if I just want to try, right? Find a doctor who's willing just to let you try. But you have to then go in with the mindset of, I know the odds are stacked against me. I get it, but I just want to try. And then you try, and it likely won't work. And then hopefully you'll feel comfortable saying, okay, well, this chapter is closed, right? Let's move on to another option. And the other option may be, yeah, I'm fine without kids. Or the other option may be, I'll consider an egg donor, etc.
I love that you said that because I echo the same thing because I do think that, yeah, why don't you don't want regrets later, if this is going to help you to move forward, then great, go for it. If an endometrioma was found once in 4 cycles, does that mean they have endometriosis?
Yes. Endometrioma is endometriosis cyst in the ovary. Yes.
Okay. Does alcohol really affect egg quality for egg freezing?
I'm a big believer of moderation. Okay. I don't think you should be drinking during your IVF cycle. Okay. But let's say you drank a few days before your IVF stim or a few weeks before. I think it's fine, but don't get drunk, right? I think that if you get drunk, that's just so much alcohol for your system to process. But I think if you had a glass of wine or a few drinks here and there before your IVF stim, I think that's fine. No, I don't think it affects your quality.
What would be a reason a corpus luteum continues to exist after a cycle, and does that negatively affect the next cycle if you did one right away?
No, so normally the corpus luteum should stay around. So when a woman ovulates, even naturally, that the egg came out and that remaining cyst is a corpus luteum, and it just starts to secrete progesterone. Okay. And it's waiting and waiting. It says, oh, are we pregnant or are we not? If you are pregnant, the corpus luteum is sustained by the HCG from the pregnancy, sustains the corpus luteum. So that's where you get your progesterone from. But if there's no HCG, the corpus luteum will sense, oh, wait, there's no HCG. And then that's when the corpus luteum dies. So the progesterone level drops. That drop in progesterone is what makes you menstruate. It's what pulls the lining out of the uterus. So you want that corpus luteum to sustain post-ovulation because you need that progesterone, should you become pregnant, to sustain that pregnancy. So it's normal for the corpus luteum to be around for a bit, but then if you're not pregnant, it's called involution. It will involute, and then you will get your period.
What is your personal opinion on long-term risk for ovarian cancer or borderline ovarian tumors? This person says her sister is now having her second ovary removed and her oncologist thinks it's IVF related.
I know. So if you look at the data, the scientific data, it says there's no increased risk of breast cancer or ovarian cancer. Personally, I agree with your sister's doctor. I think to myself, my gosh. Now, I think if you've done just a few IVF cycles, I don't think it matters. But I've had patients I had a patient yesterday from Australia. She's done more than 10. She couldn't even count. I said, was it more than 10 cycles? She's like, oh, yeah. I mean, like a lot. I feel like that can't be good for you. It just cannot be good for you. And yes, I personally think that repetitive exposure to estrogen over and over and over again has to somehow impact you. So I do think that, I'm sure, it has something to do with our IVF cycles.
Would you transfer several day 3 frozen and fresh embryos for a 45-year-old?
Yes. And that's currently what I do. So for most women in their mid-40s, their embryos don't make it a day 5, right? And 21 years ago when I started, we only transferred on day 3. We never, at that time, we didn't know how to grow to day 5, right? And we always put in 3, 4, 5 because the implantation rates were so bad. So yeah, if you have somebody who's 45, whose embryos are not going to make it a day 5, it's pretty rare. So give it to her on day 3. And I had a patient a few months ago, and it's true, most of them are negative, but I did have a patient a few months ago who got pregnant. She's still pregnant with her day 3 transfer. So yeah, it works. It just doesn't work a lot, but it does work.
At what point in the cycle do you use the growth hormone?
So you start it with the IVF medicine and you stop it with that. So let's say you're using Gonal-f, you start and stop it with your Gonal-f.
Okay. When would a reproductive immunologist be helpful?
Oh, so reproductive immunology, it's not a formal field in that there's no formal training for it. So most reproductive immunologists are reproductive endocrinologists that then develop this interest in recurrent pregnancy loss and then just focus on that. My thing about reproductive immunologists, and this is just my personal thing, is it's not a coincidence that many of them own a lab. And then they make you do all these tests, many of which are not proven to be accurate, in their own lab. The tests are low, and these are tests that people haven't even heard of before. But those tests cost about $10,000, right? So they're making you do a bunch of tests which have scientifically not been proven to be accurate in a lab that they own. So they're making money off of you doing all these tests. And that bothers me because I feel like there's a conflict of interest there. So of course you're going to make her do all these tests. So that's number one. Number two, the protocols are kind of the same, which is intravenous immunoglobulin, steroids, right? Some other immune therapy. And again, I feel that if people are at the point where, my gosh, you're just desperate, sure, do all of that, yes. Okay? When I have patients who really, I feel needed because we're just repetitively miscarrying or repetitively negative and surrogacy is not an option for them. There is a reproductive immunologist in Chicago that I refer to. Her name is Esther Kwok Kim. She has a very long wait list. But what I do like about her is that she is academically associated. So she has no personal gain, right, from you doing all these tests. So to me, I feel as if that's a little bit more objective and more trustworthy. She still does all this immune stuff, but at least I feel as if she orders tests because she believes in the test, not because she will have a financial gain from it.
I like that policy of yours. Okay. Can an endometrioma go away on its own?
So usually the answer is no, but I've seen very few cases where it does, but usually no.
What would you say is in your hocus pocus bag in terms of fertility?
So my hocus pocus list, the ERA, which we talked about earlier, but the ERA company, iGenomics, also has this other biopsy called Emma and Alice, which is for like yeast and bacteria. And I gotta be honest with you, for me, my bullshit meter goes off, right? I'm like, really? But, I tell patients, like, this company just offers this as well. Do you want with my biopsy to run all of this, or do you want just the ERA? Right? Just again, it's my job is to educate, right? And then support their decision, right? So there's that. There's also in my Hocus Pocus toolbox, there's also Receptiva. That's the biopsy actually for endometriosis. Okay. There's also a biopsy for endometritis, which is inflammation of the uterus. But I'm not a big biopsy person, so I tell patients, hey, look, instead of doing your test for endometritis, inflammation of the uterus, why don't I just treat you for endometritis? I'll just give you doxycycline, right? So I tell them, just save your money. Don't do the biopsy. We'll just put you on inflammation medication. Still in my toolbox, you mentioned the intralipid. Please remember they cannot be allergic to soy, peanuts, or eggs, okay? And the cholesterol level needs to be normal because you're basically infusing cholesterol into their vein. So I do suggest intralipid, again, in cases where I'm just like scratching my head, like, why is this not working, right? So then, yes, I will present it to them as an option. We charge, and all of this stuff costs money, right? So we charge $450 for the intralipid. I don't know how much other centers cost, but of course I was to tell them the cost. The biopsy stuff, that's like a lot. The ERA is like 800, we charge $850. If you do all three, it's like $1,500, right? So this stuff adds up pretty quickly. Also, my hocus pocus box, if I really think they have endometriosis, I tell them, hey, listen, maybe you should go to your OB/GYN and get the laparoscopy done and see if you have endometriosis, and maybe they'll find other stuff in your pelvis. Because way back when, we did laparoscopies on every single infertile patient. And now we don't because the studies have shown it, like you're doing so much surgery and you're finding nothing. But when you have a patient where I think, maybe you really do have something, I tell her, go to your OB/GYN. Maybe you should go get the surgery done and let's see what we find. Okay. So my hocus pocus box, I mentioned Lovenox, the blood thinner, because especially if somebody's either not getting pregnant or they're having recurrent miscarriages, I tell them, look, I don't think you have a blood clotting disorder, but let's just put you on Lovenox anyway. Why not? It's just thin out your blood. But the downside of it is cost, right? Lovenox is expensive. I had a patient who got a good price for it through that GoodRx program. Okay, but most insurance companies won't just pay for it if there's no clinical indication for it. Okay. And then still my hocus pocus box, I also, of course, think Eastern medicine. So acupuncture, if they've never tried it, I tell them maybe you need to consider acupuncture in conjunction with Western medicine. The other thing I also talk about is just lifestyle. So especially with transfers, and they're struggling, I tell people, we know that inflammation is not great for transfer. So foods high in inflammation, gluten, dairy, sugar, right? So I tell them maybe you want to omit these from your diet and just see if you have a different outcome. And then I talk about weight a lot. When they're not at a healthy weight, I tell them maybe you need to pause here and take time to be at a healthier place in life. Maybe it's weight, maybe you're super stressed out, etc. And then maybe we embark on the transfer.
Okay. I love the hocus pocus box. I have to use that. Okay. 2 questions for you that are a little bit lighthearted from me. If you had to swap careers for a month and you were already amazing at it, what would you choose?
Oh, gosh. Okay. So a few things.
Oh, wow.
Oh, yes. I've always wanted to own a doggy daycare center.
That's so cute.
Yes, because dogs, to me, they're just pure. Their souls are just so pure, right? And they're always just so happy and eager. And their needs are so basic, right? So that's one of them. The other one, I know this sounds weird, but I don't know what it is, but I have this thing about being a flight attendant. And I know I would hate it, I know, but there's something about it that I just wish I could be a flight attendant for a day. I just want to see what it's like. I don't know, because, and I know it's still their job, their career, but they just seem to be well put together, right? And just for your however many number of hours your flight is, be able to just provide you that service. And generally, it's pretty good. And I know I would hate it, but I just like want to try for a day. And then the other one is when I was in high school, I've always wanted to be a physician, but when I was in high school, I wanted to be like, I saw Connie Chung on TV. And I thought, oh gosh, I would love to be like Connie Chung. So I would love to be on TV to talk about something that I am knowledgeable in and confident enough that I could talk and really guide the people on the TV show about it. Yeah. So those are my,
You're missing being on Instagram then. You could have your audience. You're doing this now.
I do this much social media. I do zero social
I know.
media. I know.
But here, that's your calling. Okay. Then the second question is, do you go to bed with your email inbox at 0, or are you one of those people with thousands of unread messages in the corner of that icon?
Oh, no, I check my emails usually in the mornings and usually once a day because I'm with patients all day. So I wake up early in the morning, usually between 4 and 4:30, and I clear my inbox before I start my day. But then I usually don't check my email again, usually because I don't have time. So the next time I check my email is the next day in the morning.
Okay. Dr. Park, I have to say, I also wake up around the same time, and sometimes I will get an email from you if there's something, and I'm like, oh, we're both up at the same time. Very nice.
Yes. That's good for me to know because
Yeah.
I'm not the only person in the world up there
Nope.
early. We
Nope,
could send
I'm
each
outside
other
early.
emails. And just
Yes, I know.
Good
Hey, morning. Dr. Park, thank you so much. By the way, everybody, I wanted to say I told you would like her. She's amazing, and thank you. And someone already said that. Thank you for your honesty and your thoroughness and everything. So thank you so much, Dr. Park, for being here and for just always being just a source of information for me and everything.
You're welcome. And thank you, Rachel, for the opportunity to be on the show. It's always nice to be able to just share information with people. And I love working with you. So thank you very much.
All right. Thank you.
Okie dokie. Bye, everybody.